It's lovely to be here, and it's I've had a great day with people here, lovely people, interested. We realise that something like pain is a common problem no matter where you come from, and it looks the same in every country. The story around pain, the issues around pain, the fear around pain, the concerns, the worries, the beliefs around pain are so similar. Whether I'm in South America or in Northern Europe or in outback Australia or in the Middle East, it looks the same. And that's so interesting that there's this commonality that occurs with that. So I've called this Making Sense of Pain because that's really what we're interested in doing in terms of our research and clinical work, is that we see people who present with pain and they're disabled and they don't understand why, and the pain's affecting their life, and they're trying multiple interventions and it's not worked for them. And one of the things they tell us is that they don't understand it. They can't do the things in life that give them meaning, and it's impacting significantly on their existence. And so our interest is to say, what is it that's going on with these people with pain, and what is it we can do that will have an impact on them to improve their life? And so I'm going to start this talk with a real story of a man who had a disabling back problem.
Years ago, I had my first back pain. It was as a result of sleeping on the floor at a school camp. Then it got progressively worse over a period of 2 years. I was seeking help from my GP and went through a variety of different specialists trying to find an answer for it.
And how badly was it affecting you?
Well, it was affecting all of my movement. I was very guarded in any movement that I made. I refrained from lifting, and it got to the stage where any sort of bending was difficult and was something that I completely avoided.
Were you in pain all the time?
Pretty much. It would get progressively worse as the day went on, so I'd wake up with some level of comfort, but by midday it was quite painful, and at night it was severe pain.
So it was knocking you around a fair bit?
Yeah.
What treatment were you having?
Initially, I started to visit my physiotherapist, but that would give me relief for a very short period of time and no ongoing benefits. Then I was referred to a surgeon who got me to get an MRI, and he pointed out the areas of my back that weren't looking quite right. There was some arthritis beginning, and there was some issues with the facet joints, but he didn't think that any kind of surgical intervention was actually going to give me much relief. So then he referred me to a pain specialist to get a cortisone injection, and I had 2 of those, and they were reasonably successful, but again only for a short period of time.
That's a common story. So Martin's story started with pain that wasn't even related to an injury. It was sleeping on the floor at school camp. He was worried, so he sought care. He went to see a physio who gave him manual therapy, short-term pain relief, but the pain didn't get better. So he saw his GP. His GP did a scan, an MRI scan, and showed degenerative changes of his disc and his facet joint. That made him worry. So the GP said he had arthritis. He went to see the surgeon who confirmed this, but told him that there was nothing surgically could be done. And so then he saw the pain doctor, he's had injections, and now he's disabled. So you can see when he moves, what do you notice about the way he moves? It's protective, it's guarded, it's stiff. So this is a guy who's thinking that bending's dangerous for his back, and that's common with people with back pain. Forward bending is the most feared movement with people with back pain. And you can see that when he moves, it's guarded, protective, and it's painful, and it's affected many aspects of his life. He stopped being active, he's put on weight, he's not sleeping well, it's affected his mood, he's struggling at work. So this has had a major impact on his life. He's tried multiple interventions and it's not getting better, and he believes now that this is his lot. So the question I ask, is there anything better we can do for Martin than what he's had now? He's got a diagnosis of arthritis, he tried physiotherapy, he's had injections. What else is there for this guy? And that's my question for you for this evening. So the question then comes back, well, how did it all begin? It started sleeping on the floor. Is that a sleeping injury? Can you injure your back when you're sleeping? Is arthritis really a cause of back pain? So we see degenerate discs are very common. This degenerative changes in the facet joint and the discs, they're commonly diagnosed as a source of pain. Is that a real cause of pain? And this comes back to our beliefs. We have common beliefs that back pain is caused by disc changes, bulges, disc tears, disc degeneration. We have beliefs that pelvis is going out of place. We have beliefs that bending is dangerous. We have spines that sit in our clinic with these big red bulges sticking on them. That's telling us that backs are to be feared. We have beliefs that the more core work you do, the better you are. We have beliefs that you should sit up straight if you've got back pain. These are common beliefs. They're beliefs of physiotherapists. They're beliefs of healthcare providers. They're also common community beliefs. They're things that people, if you ask them on the street what causes back pain, they're common things that you'll hear people say. Are these evidence-based beliefs, though? Well, that's what I'm going to challenge you with tonight, because there's very little evidence for any of those belief systems. So if you do a Google hit, the number one hit in Google will say the most common cause of back pain is intervertebral disc degeneration, which means the discs are breaking down with age. Now, if that was true, you would see that back pain got worse with age. Would it not be true? And that's a common belief, that back pain gets worse with age. Well, what we know about back pain is that it rapidly increases during adolescence. It hits its peak around the early 20s, and it flatlines for the rest of your life. If you look at the prevalence of disc degeneration in adolescence, it's pretty low. It gets increased as you go through life. If you know anything about statistics, if the two lines go together, they're correlated. If they don't, they're not. And we know that what you see in a scan does not correlate well with pain experience. But in the Western world and in other parts of the world, we're treating backs like they're damaged. We scan them, we inject them, we drug them, and we fuse them. And it's made the problem worse. The more we've drugged, fused, and injected them, the more we're seeing back pain disability increase. The disability burden around back pain is now the greatest burden of any health disorder in the world. So it comes up number one in terms of years lived with disability. We're not doing a good job. So in spite of all the scanning and the various interventions, the problem's not got better. So that makes us think we have to be thinking and doing something different. So we start looking at the evidence for back pain, be it exercise or manual therapy or injections or needling or these various interventions. The evidence tells us that no intervention is superior. You can get small changes of pain relief, moderate changes in disability. This is a really tough disorder to change. And that brings us back to saying what underlies the disorder. Are we actually treating the cause, or are we treating based on our beliefs? Because the evidence would tell us that we're probably treating mostly based on our beliefs. So we look at diagnosing back pain. The first thing we have to realise is that only a small group of people have serious stuff like cancers and fractures or inflammatory disorders. Around 5% have specific pathology like a prolapse that's causing radicular pain and neurological deficit. The majority of back pain sits in this group. It's called non-specific pain or undiagnosed back pain. That means that the majority of back pain disorders who present to your clinic, if you're working in a clinic, you can't put a label on them. Well, we didn't used to be able to put a label on them until we developed the MRI scanner. The problem with the MRI scanner is it finds stuff in everybody. And so the problem there is we're starting to diagnose everybody as degenerate disc disease, and that's why Google's come up with the #1 hit. Because everyone's got it, particularly as we get older. It becomes more and more prevalent as we get older. So that's created a big problem. Now, we start looking at the evidence around this, we realise that back pain is a problem of the nervous system. So, because it's a sensory problem, it's a problem of the nervous system. In some cases, structure is important. In some cases, in many cases, loading the back's important. People tell us it hurts when they bend and twist and lift. So there is something about the physical. Back pain's also influenced by lifestyle factors. We'll talk about that. But then other factors are important, like our thoughts and emotions. And what's happening in terms of genetics is also important. We start looking at back pain, we need to consider all of these factors as potentially involved. I'm going to talk you through them. So when we start asking about pain, what is the nature of pain? Now, I imagine everyone in this room has felt pain. There's a genetic problem that actually occurs with very small people, a very small number of people, where you don't feel pain, and those people destroy their body's tissue because they don't know when they've broken a bone, they don't know when they're stepping on glass. So pain is a good thing. It's there to protect us from doing damage. The problem with pain, though, is it doesn't always reflect damage. So this image here is about a builder who stuck a nail through his boot with a nail gun. And he presented to the emergency department of the hospital with huge amount of pain and very distressed. And they had to anaesthetize this guy, put a lot of drugs into him to basically knock him out, to pull the nail out. When they pulled the nail out and took his boot off, they realized the nail went between his toes and it never pierced his skin. So what does that tell us about his pain experience? It tells us that he looked at the nail, he felt something next to his skin, he perceived that it has pierced his skin, he became highly distressed and he felt pain. So the brain can cause pain in the absence of tissue damage. That's pretty cool. So we can have pain in the absence of damage. That's what the brain can do, and that's why pain is described as both a sensory and emotional experience that's influenced by both actual or potential or the threat of tissue damage. So you could experience pain with the threat of damage not actually being damaged. Now that's interesting when we start examining people with pain, particularly back pain, because what do people in society think about backs? Do they worry about backs? Yeah, they do. Backs are regions of the body that people worry about. So we know the brain responds to the perception of threat. And if you ask people in society what they think about backs, they think bad things about backs. They think backs get worse as we get older. They think that disc degeneration is a cause of pain. They think it's dangerous to bend and to lift. They're common beliefs that that develop very early in life and that persist through life. So we can have pain without nociception, or we could have nociception without pain. We need to separate those two things. So when we start looking at pain in the back, we know there are different kinds of pain. There is nociceptive pain that you and I might feel if we put our finger in a hot flame. We pull it out because it hurts. That's a good pain, that's protective. There's inflammatory pain that occurs after you've had an injury. You've caused some tissue damage. You'll get a subsequent inflammatory process that causes that constant aching pain. That's an inflammatory pain. But then we have other kinds of pain. We have pain that you might get when you're run down and tired and stressed. You might get a headache. How many here would get a headache when they're run down, tired and stressed in this room? Lots of people. Do you worry you got a brain tumour? Or do you think I'm run down, tired and stressed? I've got a headache. Yeah, well, you might. But same with the back. You can get backache in the same way when you're tired and run down and stressed. But people don't think I'm tired, run down and stressed. They think there's something damaged in my back. Okay? And then you have a problem where someone's tired, run down and stressed, and they bend over and they get acute back pain and then they panic. Because the nature of the nervous system is that it fluctuates all the time. And the times when we're more sensitive are when we're run down, tired, stressed, fatigued and sad. And that's a common feature of human beings. And that's when we become vulnerable. Then we have another kind of pain, it's called neuropathic pain, which is linked to damage to nerves, but that's not so common in back pain. Now the interesting thing about back pain is that when you ask people who have back pain, how many of them actually had an injury? What do you think? Not that many. If they're seeking compensation for their back pain, there's lots of them. But if they're not, in fact, over 50% of people with back pain cannot think of any reason for their back pain. So what does that tell us about back pain being linked to injury and damage and inflammation? Doesn't fit. So the guy we heard about developed back pain sleeping on the floor at a school camp. What's the mechanism there? So if you're thinking mechanism, it doesn't fit with a nociceptive inflammatory mechanism. But if he was tired, stressed, and anxious at the school camp, that could be a mechanism for causing back pain. But then what did he do? He worried, went to the doctor, got given a diagnosis of arthritis. Well, do you get arthritis from sleeping at school on the floor at a school camp? No, of course not. His back didn't just degenerate that night when he slept on the floor. He had a degenerative disc before the school camp and after the school camp. Something else happened. And when you start listening to the stories of people with pain, it doesn't make sense when you start thinking structure. But it makes a whole lot of sense when you start understanding the things that can sensitize the nervous system. So when we start looking at pain mechanisms and back pain, it gets a bit complicated. It's not clear. It's a bit of a combination of factors. What we do know about backs, though, is that things that normally cause you pain, like doing this, might be painful. Other stuff starts hurting. Like we heard with this young man today, just to sit was painful, to stand is painful, to bend is painful. So things that don't normally hurt become painful. Why? Because the threshold of sensitivity changes in the body. So normal stuff becomes painful that shouldn't be painful. Okay? And that's not because the system's damaged, that's because the system's sensitized. Okay? So we need to know what sensitizes the body. And we'll come back to that in a minute. Now, there are different profiles of people with pain. Some people with back pain have very localized pain. They hurt with things that they do in terms of the way they move. For others, their pain is much more widespread. It's all over the body. And when you start looking at people with pain, and you look at these people, they look different to this. These people tend to report pain with movement and activities, where these people tend to report pain linked to other things like emotional distress, stress, lower mood, poor sleep, feeling worn out and run down. And those things we know can influence the central nervous system, the sensitivity of the system. We did a study looking at this. When we looked at these profiles of patients, we found that those people with these more widespread pain problems were very sensitive to touch and they were sensitive to cold. And that's a sign of the whole system being involved. And the cold sensitivity was at the wrist, even though they had pain to the back. Okay, so the whole system becomes involved. So when we start looking at them, they were reporting, these people were reporting movement sensitivity, these people were reporting sensitivity to cold and pressure, and a whole bunch of other factors that were linked with this. And that's where the role of emotions and thoughts and lifestyle factors comes in. So there was a study that was done taking a group of back pain patients in an MRI scanner and asking them to look at these two pictures. One was someone standing and the other one was someone bending. A number of these people reported back pain just looking at the picture. So they were lying down just to look at the picture, they felt pain. How does that work? So what's the mechanism there if you look at someone doing something that you think is threatening and you experience pain? What's the mechanism? The brain. So the brain, that's no different than putting a nail through your boot and thinking that you stuck a nail through your foot, that you feel pain. Looking at someone bending or doing something threatening and you feeling pain is the ability of the brain to mirror threat and to actually embody it. Fascinating. And when they looked at that brain in the fMRI scanner, they observed there was activation of the emotional centers in the brain, the centers that map emotional responses, the prefrontal area.
Phantom pain.
It's like a phantom pain. It is, exactly. And we say to people, you know, you can chop your limb off and feel pain in a finger that doesn't exist, right? Or you can have pain in a finger that looks completely normal and the structure's okay. And that's because the pain is generated, can be generated from the brain. And there's lots of evidence for this, that within pain that persists over a period of time, there's reorganization that occurs in the brain. That alters the resting state of the brain. It alters your ability of the brain to create inhibition, natural inhibition. So we have a pharmacy in our brain that naturally keeps our body in balance, and that pharmacy gets affected. So the things that normally keep the system dampened becomes inhibited. We get disruptions to the sensory motor cortex, that we start having alterations in our perception of where our body is in space. We start changing the way we move. We start holding tension in body parts that are not normally meant to be tense, and that could be associated with pain. And there is evidence of a loss of grey matter in the brain of people with persistent pain. So when we start looking at how closely an MRI scan correlates with back pain, not much. We look at how closely changes the brain map match with back pain, it's much stronger related. So when we start thinking around pain that persists, we're thinking the nervous system is much more important than the structure in terms of understanding why the pain persists. If we look at anatomy, then, and we take a scan of someone's spine, how common are these findings in people without pain? So in an average middle-aged population, almost everybody has a degenerate disc. The majority have lost disc height, have got disc bulges. 1 in 3 of you people in this room have got a disc prolapse if you haven't got back pain. So that means these are common findings in people without pain. Now, if you're walking around with a disc prolapse, why is it you don't have pain and someone else with a prolapse does have pain? If you've got a degenerate disc, how come you haven't got pain and someone else does have pain? We start looking at what impact it has when you start scanning people's backs and tell them that their discs are worn. It has a poor effect on their health. It affects their perception of their health. They're more likely to have surgery. They'll have a poorer outcome. So why is that? Because we start telling the people that back pain is caused by being damaged, it makes them worried. It makes them protective. They start avoiding things. They start behaving differently. So we've created a huge problem. So this study looked at taking a group of people and following them for 3 years. They scanned a large group of people, they MRI'd them, and they looked at what showed up on a scan, whether it predicted those people having pain 3 years later. What do you think predicted back pain 3 years later? Nothing on the scan. Annular tears, disc degeneration, disc bulges, and facet joint arthrosis did not predict back pain. So that guy, Martin, was told he had arthritis of his back because he had facet joint arthrosis and disc degeneration. That is not supported by prospective studies. The thing that predicted future back pain was depression, not the scan. So people who had a depressed mood at baseline were more likely to report back pain 3 years later. But the scan results didn't predict anything. Isn't that interesting? Because that is not what people in our community believe. So what about physical factors? We know that there are certain things that increase risk for back pain. So repetitive loading, heavy lifting has an increased risk. But interestingly, that risk is much more increased if you're tired and fatigued and run down. So if lifting is coupled with being tired and fatigued, you've got a higher risk of back pain. And being tired and fatigued reflects a change in your immune system. So when we're run down and we're tired, we're much more vulnerable to pain. So it's not just about the tissue damage, it's about the sensitivity of the system again that looks like it's important. We know that people with pain have pain when they often report pain when they move. Some people have pain with forward and backward bending. So some people have pain with forward bending, some people have pain with backward bending, some people have pain with both forward and backward bending, right? And we examine these people in a clinical setting. We've done some studies looking at these groups, and we've found that people who have pain with forward bending and more disabled have more catastrophic thoughts. They think terrible things about their back. They're more slower than they move. People who report pain with both forward and backward bending have more pain, are more sensitized, are more likely to be depressed, have lower confidence in their ability to move. What does this tell us? It tells us that it's not just about the movement, it's about your thoughts about the movement. It's about the level of sensitivity of the system that influences whether you have pain when you move or not. All of these people reported increased fear and of perception of their body with movement compared to normal populations. And you start looking at the things that are predictive of pain, they're much more like this. Things like how fearful you are, how confident you are, how worried you are about your back are more predictive of your pain experience than what you see in the scan. We know that people adopt different patterns of movement with pain, and you described that man today as his movement looked slower, stiffer, and guarded. And if you look at the systematic reviews of examining what happens to people in pain, those are the things that come up. People with pain move stiffer, slower, and guarded. If you look at what that looks like, if you measure the muscles around the trunk, do you think the muscles are doing more or less? If you're stiffer, slower, and guarded, is that easier or harder on the body? It's harder. That stiffness is like creating compression through the system. So we describe this a bit like clenching your fist. If you move your wrist, it's nice and loose. If you clench your fist and move it, it's stiff, right? So stiffness is created through co-contraction of muscles. Which muscles in the back create stiffness? The abdominal wall and the back muscles when they co-contract. And they co-contract with intra-abdominal pressure. So when you look at people with back pain, typically they protect their backs when they move by creating intra-abdominal pressure, tension in the abdominal wall and the back muscles. That's no different than clenching your fist. So we would say to someone, if you've got a sore wrist, why would you walk around clenching your fist all day? Do you think it does? No. Yeah, so the perception is you've got to protect your wrist all day by clenching your fist. But if someone came to you in your clinic and said, I've got a sore wrist and it hurts every time I pick something up and it's painful when I move it, and you looked at them doing that, what would you say to them? Have you thought about relaxing your fingers? Letting it go and moving it normally? And they go, no, that's dangerous. Is that any different? Someone with back pain who's protecting it, guarding it, holding it tense, and they think it's dangerous to relax and move? Because that's what we see people with back pain do. And they don't all move the same. So they have different strategies to move. And if you look at this guy, when he bends, he extends his thorax, braces his stomach, and then he fixes his back on the way back up. For this lady, she holds her back in lordosis when she bends. So people adopt different strategies, but the common features are they're doing more. They're protecting, they're guarding, they're generating intra-abdominal pressure. And we've identified this with some of Wim Dankert's research. He's looked at people with back pain, and those who are sensitive to flexion tend to sit flexed. Those who are sensitized to extension tend to sit really lordotic. And it's like doing the very thing that hurts them. When you ask these people, what hurts your back? They say, oh, backward bending's painful. That hurts. And you look at how they hold themselves in the direction that's painful. That's like saying this hurts, and you walk around all day pulling your finger back. Doesn't seem logical. Now, why would you, if it's logical in your finger, why would you do it for your back? Why would we adopt strategies of movement and postures that hurt us? Do you think? Because that's not very smart, is it? They don't know, is what it is. Backs are behind us. We can't see them. When you last looked, you'd probably hurt your neck to try and look for the back. Backs are behind us. People with back pain don't know where they are in space. They start losing perception of where they are in space. And there was a lovely study looking at this, where we looked at people who had pain-related to flexion. They brace with their abdominal wall to preload themselves to flex when they bend. Where those sensitized to extension actually lock their back into extension when they bend. Crazy. And when we look at the EMG traces of these people, the people without pain relax when they bend. People with pain are tense when they bend in their back muscles. And yet what's the common view is? Give them more core stability. Do more of the things that they're already doing. Doesn't make sense. Why would you do more if you're already doing it? That's like saying giving clenching exercise to someone who's walking around clenching their fist all day. It doesn't make sense that you would do that. So when we looked at people without pain compared to people with pain, we found that the people with pain find they can't relax their back muscles. They tend to hold these tense, guarded postures, and they initiate that with when they move. So a really interesting study looked at these people and they asked them to reposition their back in a neutral position. So those people who had pain when they had when backs were extended, and they were brought back to a mid position, and they were asked to refine where the middle position was, they went back into the extended position. They biased themselves back towards extension. Those people with flexion-related pain, when they were brought to a mid position and told to find it again, went back towards a flex position. So there's this orientation of people with back pain to go back into the direction that hurts them. That's interesting, isn't it? So you can see it on this graph here. The people without pain were really accurate in their repositioning. The people with extension-related pain or flexion-related pain tended to head back towards flexion. Those with extension-related pain tended to bias their backs back into extension. And if you ask these people who sit up straight why they do it, they'll tell you that it's good for them. Everybody should sit up straight if they've got back pain, shouldn't they? That's what they'll tell you. We saw a guy today who thought it was good to sit up straight and it hurt him. You go, why are you doing it? Well, everyone believes that, don't they? Everyone's told it. It's on the brochures. It's in the internet. Sitting up straight's good for backs. Is it? Well, not if it hurts. Clearly not. So what do we know about back pain? We know that the more pain you have, the more disabled you are, the more depressed or anxious or more catastrophic your thoughts, the more fearful you are, and the lower confident you are, the more you tense your back. Okay? So what that tells us is that's the brain's way of protecting itself when it's threatened, is to protect it. That's why we see people with back pain move slow, guarded, stiff, because they're protecting their backs. And what do we tell them to do? Be careful when you bend. Lift with a straight back. Sit upright. Work your core. What does that do? Makes them guarded, slow, and stiff. So in a sense, we're feeding the problem by giving them more. That doesn't mean they need more stability. They need to chill out, relax, and need to learn to move normally again. But that's not a common view. That's not commonly given as advice to people with back pain. So what about lifestyle factors? Well, we know that people with back pain, if they're underactive or overactive, if they're too sedentary, obesity, not sleeping, they are all predictors. And they influence inflammatory processes, they influence your immune system, pain threshold, that can leave you sensitive as well. What about within the cognitive domain? Things like how you think, your beliefs, your fear, your vigilance, your emotions, your behaviours are all predictors of pain. And social factors, stress within home, family, those are factors we know can be predictors of sensitising the nervous system, can affect your pain. We know that if you have negative beliefs about the back, are distressed and have a lack of confidence, that can leave you more disabled. It can increase the sensitivity of your system. We know that a lot of people develop these beliefs around the things they've been told by healthcare practitioners. That words like chronic instability, wear and tear can have negative effect on the way people start to think of themselves that affect their confidence and increase their fear. And so we have a huge role to play in terms of the language we use for people with pain, because it can have an enduring negative effect on them. We know that there are social factors we talked about that can impact on the sensitivity of the system. So the more distressed the person is, the more pain they feel, the more disabled they are, the more bothered they are, the more likely they've had to have stress-related factors in their life, the more likely they have pain when they bend. They'll perceive that their body's more distorted, they'll be more sensitive to touch, and they're more likely to have non-specific complaints like tummy ache, headache, dizziness, fatigue, other health-related complaints. So this is clearly not a problem just of the structure. We know that genetic factors also play a role. There are certain genes that are related to tissue sensitivity, that if they're linked to environmental factors like early life stress events, leave us vulnerable to pain at a later stage in our life. So there is also genetic heritability. So we think of that young guy, Martin. He was stressed at the time that he was at their school camp. And he developed pain, and he started thinking bad stuff. He started thinking his back was damaged, it was dangerous to move, he's never going to get better, he was feeling low and depressed. He started changing how he moved, he started protecting his back, he started avoiding physical activity, and he got into a bad state. Now, when you start thinking around pain as a vicious cycle, we start seeing that often there's a context of vulnerability that creates a trigger. Once the trigger occurs, how you respond to pain is to whether you get out of it or not. If you respond to pain by protecting it and worrying about it and fearing it and guarding it and avoiding, you get yourself trapped. And that's where we have a role to change the way people understand pain, think about it, and manage it. So we would say, well, how do we manage people like Martin? Number one, we've got to realise that pain is not about structure. In his case, it's about sensitized structures, but for lots of other reasons. We've got to think about the things in life that are important, and we've got to start looking at modifying the things that we can change. I can't change his MRI scan, but I can change the way he thinks about it. I can change the way he moves. I can change his confidence about the way he moves. I can change some of his lifestyle factors. And so when we start looking at managing pain, we look at changing pain beliefs and behaviours. So it's been said that you can't change someone's beliefs until you change their behaviour. So we take a behavioural approach to managing back pain. The first part about this is to change how people think about their backs. When we ask people about back pain, what are you thinking is the cause of your pain? So the young man we saw today he was told that he had some deformity of his back and he shouldn't go to the gym and exercise, ever. He was thinking that he was going to maybe end up, as he gets older, getting worse. He was 24. He might not be able to work. So those are thoughts that have an enduring negative effect on the body. So if we start explaining to people that pain is not just about structure, it's about many things. It's about your mood and your behaviours and your thoughts. It starts changing things. We start challenging beliefs that back pain is caused by damage. We start giving people different strategies to manage their pain. We reassure them that backs are tough structures. They love to move. They love to bend. They love to be used. We start setting goals around the things in life that give them meaning, and we give them strategies to change their habits. That's what we do with these people. We tell them that back degeneration is common in people without pain. It's common in people who are athletes. It's common in people who are loading their backs all day safely, that they also have degenerate disc bulges and annular tears and prolapses. That backs shouldn't be feared. And this study gave epidemiological evidence for people with back pain and showed that these people are less likely to end up on narcotic prescriptions for back pain when they are being told that. Because it reassures them, it reduces their level of threat. We tell people that movement is good, that if it hurts, it's safer to relax and breathe and move normally than to protect and guard it. That pain doesn't mean you're damaged, that backs can be trusted, that it's safe to bend, that backs are strong. We take people back to the things they thought they couldn't do and gradually change them. So we use behavioural experiments. We say, you think it's dangerous to bend? Let's try it in this position. Let's get you to bend in a safe way. Maybe lying on your back, bring your knee to your chest, bending and sitting, and then take it back to the thing they thought they couldn't do. And usually the thing they can't do is the thing that gives them most relief. So we target the things that hurt them, are feared and avoided. We get them to be relaxed when they move. We normalise the way they move, and we discourage pain behaviours. So pain behaviours are things like breath holding, propping, supporting off the chair, limping. We don't like them. We think it tells the brain that there's something wrong. Then we take them back to the things in life that are important for them. Things in life that give them meaning. Bending, playing with your kids, being active, going to the gym, whatever it is. We don't want people frightened. We get them to practice this to reduce their sense of threat and to build their conditioning. We encourage people to have healthy lifestyle, good sleep, regular activity, to set goals around that activity. That's healthy for your back. So what does that do for someone like this guy, Martin? We look to change the mindset. Don't panic when you got pain. Think your back's healthy and strong. Pain maybe because you're system sensitive, you're tense, you're stressed, but not because you're damaged. Get back to doing the things in life that give your life meaning. Move in a healthy way. Adopt healthy lifestyle. You can only do that when people trust you. So this is the story of Martin.
What he said to me that made the difference. He didn't really spend a lot of time doing what physiotherapists would generally do, which is manipulate you and move you around. He helped me to understand that the pain was ongoing because I had come up with new ways to try and avoid hurting my back. He looked at my MRI scan. He told me that the condition of my back was not perfect, but he had seen people with far worse backs who could live reasonably pain-free. And that was really encouraging to hear that.
It would take a fair bit of courage to stop guarding yourself like that. Tell me how you moved towards changing the way you walked and guarded yourself so that essentially your back was freed up.
Well, there were a few things. One of the first questions he asked me was whether I could touch my toes. And I attempted to get as close to touching my toes as I could. Probably got my hands to about my knees, and then I had to give up because of the pain. And over the course of that first session, he asked me to try a few movements and reassured me that they were going to be safe. And at one point in the session, he asked me just to sit on a chair and lean forward. And then he asked me to see whether I could touch the floor from a sitting position. And then he just told me to stand up. Then he told me to look in the mirror, and I looked at myself touching my toes. 5 minutes after, I couldn't do it. And I just broke down and cried. I couldn't believe it.
Before it was having a more permanent effect on you?
Well, for me, the effects were fairly quick. On my second appointment to see him, which was a week later, I had noticeably less pain. When I started to bend forward and use those muscles that hadn't been used for a long time, the effect was fairly instant. Even in a week, it was probably half the pain that I had before, and within a month, it was really reduced. I wasn't feeling pain during the day, maybe a little bit at night if it was a tough day.
And how are you now?
Well, it's been probably about 6 months since my last appointment with Peter, and there's only been 2 or 3 times when it's been quite sore. And the difference for me now is I didn't panic. Pain used to make me panic a lot, but now the mindset's very different. I have pain and I think, all right, I need to do some stretches, and 2 or 3 days of getting back into my stretches, things seem to be back to normal.
So why did he change? So this is the same guy. The 2 clips are 3 months apart. When he first came in, 3 months later. What's different in the way he moves? What did you notice? What's different? When he came in, stiff, slow, guarded. At the end, relaxed, normal, fluid. Yeah? If you looked at the EMG of the muscles of the back, one's guarded, protective, the other, active, relaxing, active, relaxing. That's the sign of a healthy back. So ironically, he thought protecting his back was going to do him good. It left him trapped. So it wasn't manipulating his back, it wasn't injecting his back, it wasn't treating the disc. It was giving this guy a change in his mindset. A belief that to respond to pain by relaxing and moving normally and trusting your body and getting back to living was so much better than what he was doing. So what's the evidence behind this? Well, we screen people's beliefs. We ask them about what they're thinking. We look at them from a multi-dimensional perspective. We look at their behaviors, the things that hurt them, and then we take them back and look at challenging both the way they're thinking and the way they're behaving. There's one study that has been conducted which compared what we call this cognitive functional approach to a traditional manual therapy exercise approach. And this was a randomized controlled trial that had a 12-month and a 3-year follow-up. And what we found is that if you looked at disability levels, the manual therapy group improved, but the cognitive functional group got significantly better. And these are large effects that were maintained 12 months later. And this was also the case for reductions in pain intensity that were maintained 12 months later that were superior to the manual therapy exercise group. 3 years later, when we looked at these people, they're still better 3 years later compared to the other group. Now, they're significant results, and this study's been reproduced in 2 other centres in the world because people don't believe those results. They think they're too good. When we looked at these people, they were less likely to have an episode of back pain. They were less fearful of their backs. Their mood was better. They had less need for treatment. They had less time off work, and they were more satisfied with their treatment. When we've done qualitative studies to ask them what they thought has changed, they've said, my mindset's changed, just like Martin said. I'm thinking differently about my back. I used to think my back was caused by damage. Now I realise that when I'm stressed, I'm more vulnerable. When I'm tense, I'm more vulnerable. So I've got strategies to manage that in a different way. So like Martin said, when he had pain, he used to panic. Now when he said, my mindset's changed, when I have pain, I stretch, I move, and it settles down. I'm in control. So giving people independence, providing them strategies of pain control, and getting them back to doing the things in life that are important. The people who don't respond still think they're damaged. They're still protecting, they're still guarding. And not everyone buys the story because the alternative story is so strong. It's everywhere. It's on the internet, it's with people you talk to. You get it from many healthcare practitioners who'll tell you to be careful with your back, protect it, don't lift, don't do this, don't go to the gym, don't pick up your kids. Be careful because you might damage it. That's a common belief, and I think we have a huge job to do to change the belief of our society around backs. Backs are not to be protected and feared, they're to be used and trusted. That backs need healthy lives, healthy thoughts to keep them safe. So where to next? Well, we've got lots of studies that have validated this approach. We're testing it in other centres. We're looking at how well it can be implemented in health settings. We're looking at training systems, and we're looking at understanding why people get better, because we're not quite sure exactly what they do. They tell us they do. We think we know, but we don't really know. So how do we make sense of back pain? Well, we think that to make sense of back pain, you have to think more than structure. You've got to think of the person and their life and their lifestyle to understand what's going on. We need to be flexible in the way we deliver interventions to people with pain, to target the things that are driving it, and they're often around the beliefs and behaviours. We think that this is one approach, but it's not the only way to do it. But the fundamental foundations of this approach are around building confidence, changing mindset, getting people back to doing the things in life that are important, and we think that's an important thing to do. So this work is underpinned by a large group of people, well, I want to just acknowledge here, who are involved in our research team, and I thank you tonight for your listening to me. So I'm happy to take questions if you've got any. That's a whirlwind kind of overview of what I'm doing here in the month, been doing here in 2 days.
Thank you, very inspired speech today. And thank you for coming here to celebrate with you. Actually, what's your experience with professionals, other professionals, with changing the behavior of the patient?
It's a huge problem.
Yeah.
So one of the biggest problems that we have in Australia and different parts of the world is there's an industry that's profiting off people with pain.
So
And it's a radiology industry, it's a drug industry, it's an injection industry, it's a surgical industry, and it's making a huge amount of money off people with pain.
yeah.
So
Especially, I believe the medications.
it's huge.
The pain
Opioids,
Yeah.
massive problem.
Yeah, it's a
So
massive-
we have a massive problem in Australia that's getting worse. We have an increase in prescription drug addiction now that's occurring around opioid prescription for back pain. It's a huge problem. And the evidence for opioids for back pain suggests that actually for a short period of time you get pain relief, which is no better than anti-inflammatories. But then you'll get an increase in pain. So it inhibits your body's natural opioid system and it actually causes more pain. That's a huge problem.
So, do you give any, education materials for professionals?
Of course we do. And we put stuff on the internet now because we want to educate the population. So if you follow our, I'm not really
Only one word may change the patient behavior.
exactly.
Or destroy what you built for 3 months.
Exactly. So if you look at following us on Twitter or looking at this website, and you guys have put this into Arabic, so your patients can read this. So we have this website that's open and free.
Yeah, I
We
think
put up
there's-
patient stories as well, and there's a recent video we put up called "The Facts and the Truth," the belief. What is it? The myths and the truth about back pain, and that's around patient stories talking about how they became trapped and disabled with pain and how they got out of it.
I think there is a very interesting book that's Suffering Pain by David Falk.
That's right. Yep.
Yeah.
Yep. There's a lot of resources that are starting to occur, but it's really hard to change this. Because these are not just beliefs of healthcare practitioners, they're societal beliefs, they're cultural beliefs that we've encultured in our population around the world that backs should be feared and protected.
So it's our jobs, not
It's all of our jobs.
Yeah, patients or just
It's
helping with
all of
something.
our jobs, yes. Yeah. And one of the things that I think one of the most powerful things is you can't tell a person not to be fear their back, you can show them. And it's the showing that will have the main effect. Telling will have no effect, but showing is the key. And that's why we need confident physiotherapists who are brave to get people to do things they're frightened of. That's important. Doing it in a sensible way, that's caring for the patient, not obviously frightening for the patient, but doing it in a way that builds because we think we need to build a confident workforce. Because when we talk to physiotherapists, we see a lot of...
We should be careful when treating these kinds of patients because most of the problem is central problem more than peripheral problem. So too much manual therapy and too much, work in the peripheral will not give, great...
Well, manual therapy can give short-term pain relief, but it doesn't change the trajectory. So we would say that using your hands is important because you can use your hands to provide facilitation, encouragement, motivation, reassurance. But as a treatment, it will be limited. It can create a window of opportunity to change people, but as a treatment in itself, it's limited. Any other questions? Yeah.
Some patients, they don't really follow that protective, the correct way to lift things, the things that the instructions that we keep telling them, they don't really follow it. They don't do the protective, they don't protect their back from the behavior that you just talked about, and they still have back pain. Although they don't follow these instructions that's in the society and the healthcare keeps telling them. And also in the MRI, there are visual changes. So in these cases, they don't have like psychological problem that they believe that they have to protect their back, but they still have the pain.
So the question then is why? Why do they have the pain?
Yeah.
That's your job.
Yeah.
Work it out. So you're telling me these people move completely normally?
Yeah.
And they have pain?
They live the whole way.
So what's the wrong way? So if they're not moving, if you're saying that these people are not moving normally, that means they're guarded and protecting their back still?
I think she means that they are not stiff all the time or
Yeah.
following the proper body.
Yes. They don't follow all the instructions. They don't.
So I suppose, I mean, it's hard for me to reflect on what patients you're talking about here, but what? That's right. That's right. So part of our job is to sit down with the patient and understand why they're in pain and what their experience is, and that takes time. So we had this example today. This young man, and he came in, and I said, "Are you protecting your back?" He says, "No, not at all. No, I'm not protecting my back." Have you modified anything in your life? No. But after talking to him for 15 minutes, he stopped going to the gym. He avoids bending. He avoids lifting. He's tense all the time. So he's telling us he's doing everything normal. He's not. So sometimes there's this kind of disconnect with people. They tell you one thing, and you look at them, they're doing something else. And you can see this when you examine them. You go, so we look at functional things. So someone says to me, it hurts when I bend. Show me how you bend. So what's your strategy of bending? And what he does when he bends, he braces himself when he bends. So every time he bends, it makes him sore. So he's thinking he shouldn't bend. But what after we found out, and once we got him to relax and to bend and to relax when he bent and not brace his stomach, the more he bent, the better he felt. So it's often through the doing that you'll change their beliefs around their body. And we use the experience of getting people back to do the things that are threatening for them or painful for them, to do it in a way that is more relaxed and not thinking around protecting their back, often gives them a positive experience. Are there other questions?
Thank you, Peter, for your interesting presentation. When it comes to patients teaching or education, there are different models, and you have to be aware of the neurobiology model,
Sure.
the cognitive behavior,
Yeah.
the classic biomechanical.
Yeah.
So, do you think is there any superiority between these models, or it depends on the client?
Yeah. So we would say that I think there's growing suggestion that healthcare needs to be personalised to the individual. So any approach to educate people that is generalised is probably going to be a blunt. It's a bit blunt, if that makes sense. It's kind of like if I educate you guys all about back pain, we tend to say, when we ask people about what they thought, they go, yeah, that's really interesting, but it's not relevant to me. So when you take the person's story in their context, and you understand what they're doing in their life, and you understand the things that they've changed or avoided or protecting, and their worries, and then you put that back and you examine them in terms of the things they can't do, and you put that back in the story to place the. It's like someone brings all the pieces of the jigsaw puzzle in, but they don't know what the picture looks like. They've got all the pieces in a bag, and your job is to put the jigsaw puzzle in to make the picture. And they go, I never knew that was a sunset. I just knew there was a whole bunch of these pieces that were sitting there. I think that's what we do for them. Now that may involve pain neurobiology. It may involve explaining to them about MRI scanning and the structure of the back. It may involve explaining to them about good strategies and healthy ways to move. It may involve explaining about healthy lifestyle. But explaining about healthy lifestyle for someone who's got one, that's a bit of a waste of time. To explain to someone that they don't need to worry about their back if they don't worry is a waste of time. So personalising it, to me, makes sense. That you target the individual by personalising it for that person. And I'm sure that's what you'll see will become the dominant model in the future. I'm sure of it. I'll be very confident. Because any generic approach to education will be limited. Because it may work for some, it won't work for others.
Makes our job more difficult.
It makes our job more enjoyable.
Challenge.
I think enjoyable, actually. It's way more enjoyable. If you look at all the evidence around job satisfaction, that our satisfaction of our work is much better when we have rich communication with our clients. It protects us against burnout, protects us against litigation. It means that our clients like us, they're more likely to refer their friends to us. It means we're busier. It means you can charge more for your consultations if you want to. It's good for every part of our business.
So this one's apply not only for low back pain,
Of
it's
course.
apply for
Absolutely, yeah. So we're now doing research into OA knee because we know that 20% of knee replacements do badly. So we're looking at, and the predictors of people who do badly with a knee replacement are obesity, mental health, and tissue sensitivity. So we're seeing the same things come up. We're also doing research around the hip because we've seen a lot of anteromedial lateral hip pain and the predictors look similar again. These people are being told they've got worn joints, they're starting to become frightened, they start protecting and co-contracting, they become avoidant, they become painful, hypervigilant, same story. We're doing work on shoulders as well. So we're seeing the very similar stories, and looking at the results look very promising. So it's just how human beings make sense of pain, is that we think protecting pain is good. And for the musculoskeletal system, usually, unless it's broken, we don't rest it. We use it.
Question.
Yeah.
Thank you very much for your wonderful talk and wonderful this turning over for thinking not only for the body as well thinking of the brain itself. So I think that respecting the brain and respecting the pain and then how to deal with it in another way, it's the meaningful thing. Thank you very much, and I have been seeing some of your videos in the internet about those patients and a lot of people that they are not jumping and then they first jump.
Yeah.
So, do you think did you think of educating physiotherapists people about this condition more?
We're trying. With the research we're doing at the moment, we have a number of projects occurring all around the world, and the first thing we're trying to do is to build sufficient evidence that this makes sense, and all the evidence is heading that this is a good way to go. The other thing we're doing is looking at the best way. We're trying to work out the best way to educate physiotherapists and equip them to implement this into their practice. And that's ongoing research that we're involved in. And the third thing we're doing is looking at applying this around other parts of the body, because we think this is something for the whole body, not just for the back. So there are things that we're doing, and that's why we put up, the website we're putting up. We pay for these videos to be developed, to put them on the internet, because we think it helps build the confidence of therapists and also for their patients. They can send patients to look at the video and get them to reflect. And there's something about a person's story that has a lot more. It comes down to education as well. If you look at things that people remember, they remember stories. So they'll listen to someone in pain and listen to their story, and that will have a much more powerful impact on them than listening to some generic education, I think. So people's stories are very interesting. And we say that with examining a patient. I can never remember a list of questions, but I will always remember someone's story. So when we examine people, we really listen to their story, and we develop a story around their pain, rather than ticking boxes on a list. Because ticking boxes on a list, you can't remember. A story you will always remember. I will always remember that young man I saw today.
If the patient is seeking the physio.
Sorry?
If the patient's not seeking the physio. So do you think may develop other source of pain? Let's say initially they have back pain, and then may develop shoulder pain or back
It depends.
pain. They're not seeking physio.
Well, they may be healthier
Or
not
they
seeking
may
physio
be
if they get told their backs are damaged. But what we know about people who seek care for pain, so there have been some epidemiological studies that have looked at populations, and they've divided people into, they looked at a population who get back pain, and they've looked at those who seek care and those who don't. And what predicts the people who seek care is a poor education and greater levels of anxiety. So people who are worried are more likely to seek care for pain. People who are less worried and more confident will manage it themselves. Now, the worried people, if they seek care and they get good reassurance, that's fantastic. But if those people get scanned and get told their back's worn out, they're very vulnerable. And so I think it's important that when people are seeking care for us, for pain, it's because they're worried. It's because the pain worries them, or they're concerned, or they don't know what it is. And that's our job, is to make sense of pain for them and to give them strategies to build their confidence. So not seeking care, they may be fine. They may be fine. No other questions?
Do you recommend this approach for any patient with back pain, or those you already know have psychological, social factors
No,
that are
no.
predominant? Because
So, yeah, sorry.
there's some patients may not have that dominant psychosocial factors.
Okay, so it depends on what you describe as a social factor. If you have persistent back pain, you'll have beliefs about it. Right.
If you say persistent back pain,
Yeah.
if the patient does not have,
Okay.
let's say,
So-
an acute episode
okay.
of
So
back
if someone comes to you with an acute episode of back pain, then the first thing you want to know is why. How did it start? So if they've bent and twisted awkwardly and lifted something and they've strained their back, then we would treat that no differently to the sprained ankle. Okay? So the first thing you'd say is you sprained your back. It's no different than a sprained ankle. We strap you up, we immobilise you for a couple of days, then we get you going and we'll get you moving, you're going to be fine. That's our job. So our job is to reassure people with pain, the natural history is good, manage it well, think smart about it. So of course we're not going to go into a history and go, are you depressed, are you miserable, what are you thinking about? But if they come in and the other situation now is that someone who comes in with acute back pain, like I saw 2 days ago, she comes in looking like this, walking in with an acute back pain. And I'm going, whoa, what's going on here? She's very stressed. She's hyperventilating. She's thinking bad things. I'm prolapsed. Now, my job is to screen her, number one, to make sure there's nothing bad. But there was no injury. She's going, oh, I've got a prolapse, I've got a prolapse. I'm going, oh, let's have a look. You can touch your toes. You don't have a prolapse. Straight leg raise, normal. So the first thing we do is we screen them. And we go, well, what's your history? Have you got any signs of radiculopathy, neurological deficit? If not, I'm not worried about a prolapse. You've got acute back pain. How did it start? No cause. Okay, so tell me what's been going on for you. It's Christmas. I've been stressed out. I'm not sleeping. I'm run down. I've got a kid who's not doing very well. I'm worried. I've got relationship issues. I did a minor event and I got back pain. So I know straight away that's a different story, right? So the history is critical. Someone with a biomechanical event who has a flare-up, treat it like a sprained ankle, acute sprained ankle, it's going to settle down and go fine. Someone who comes in with an acute flare-up, highly distressed, with no biomechanical trigger, you're thinking other stresses or other sensitizing factors are likely to be involved. So the history gives you that information, actually, as to whether you chase down that path. But the other thing that we have at our fingertips is every one of you can screen your patients through screening tools. So the Orebro or the Startback screening tool are validated screening tools that screen for distress, fear, mood, and bothersomeness. And they are nine item screening tools that will take your patient 1 minute to do, that will give you that information within a second. And we get everyone who comes into our practice to fill them up. So when they walk in the door, they're not always accurate.
The both or one of them.
We actually use the Orebro because it's for all pain. So the Startback's just for back pain. We see people with all musculoskeletal pain. So we use the Orebro because it's for all pain disorders. It's very useful. So no, not everyone with back pain is depressed. But if it's persistent, they'll have thoughts. And usually they're worried. That's why they come to see you. So we can see people who've got negative thoughts or beliefs because of advice they've been given, but they're not depressed. And they're not anxious. They might be a bit worried. But that's normal. So we're not talking about we're not trying to be psychologists here. You can have pain-related distress. That's not because you've got a mental health problem. And there's a lot of stigma around talking about emotional factors. We don't even call them that. So what are you thinking? What are you feeling about this problem? Thoughts and feelings are different. People understand that. That's different than saying, are you depressed? Are you anxious? Those words have connotations that are not helpful for people. But to how you feel and what you think, that's normal. You want to know that when someone's distressed. And I think part of our job is being comfortable to ask. And people like it because they think you care.
what do you think about those who have sort of biomechanical origin from the and like being treated, as you said, it's like we treat them obviously like sprain ankle, but
Yeah.
There are some kind of clinicians that would give advice such as you need to be careful. You have more of you have more born to have an injury rather than other people.
Right.
So can those kind of patients turn to be in the future people who have highly susceptible of
Yeah. Okay.
of,
Okay, so it depends on the so a number of things come to my mind on that question. So if you look at disc prolapse, genetics is the strongest predictor of prolapse. Okay, so there are people who are genetically vulnerable to disc prolapse, but it's like heart disease. You can have a genetic predisposition to heart disease. You can modify that risk by other things like, do you smoke? Are you active? Are you overweight? How much you're sleeping, are you stressed? If you manage those factors, you can modify your risk. So if we see someone who's got a risk for disc prolapse, that could be a genetic risk. We would say to them, you need to be really good about your health. So keep your back strong, keep it fit, keep it active, make sure you have a healthy lifestyle. Because the things we know can interact with that would be abdominal obesity, sedentary behaviour, poor muscle conditioning. So we would maximize those things to minimize their risk. Now, it may be that that person's not ideal for something like being an elite rower, where they're doing repeated bending loading of their back, if that's part of their inheritable risk. So it may be that you shift them off to do some other kind of sport. Okay? So when we look at risk, we always think of it from a multi-dimensional perspective. So the other scenario that we'd say is that the greatest risk, if you look at predictors of episodes of back pain, the greatest predictor of a future of back pain is a history of back pain. That's actually the strongest predictor. But other things that are predictive are being fearful of back pain. So if people are worried and fearful, they're more likely to hurt themselves. So the irony is the more you worry about it and protect it, the more likely you are to have it. So that comes back to building people's confidence around getting them healthy, body conditioning, healthy lifestyle, build their confidence and their conditioning so that you make them conditioned for their task. So we've done this with rowing, where we looked at people who've got back pain rowing, and we've made them really fit, really strong, give them great body control, educate them, and it's significantly reduced their risk of future pain.
But what do you you mentioned now that people with fear of back pain, they would be at greater risk.
They are greater risk, yeah.
So would you recommend that identifying those people when they come with an receptive origin of pain? So would you communicate differently with this sort of patients to any different patients that it comes with laying back, he doesn't have any kind of fear or...
Yeah. So people who are frightened need more of our attention. So fear is an interesting thing. We're doing one of our PhDs looking at fear, if I'm getting the question right now.
Yeah.
People who are frightened are usually people who are not so confident, more prone to anxiety, more worrying, and that you'll see there's a kind of crossover there. But fear is also driven by having something that's really scary that's happening to you. So you'll hear this with people with back pain, that they may have developed back pain and it was terrible. They'll say it was 10 out of 10 pain. They couldn't control it. They didn't know what to do. They got stuck. They couldn't move. And there was some really terrible event that marks its place in your brain. Okay? So the brain is a part of our evolutionary process of protecting ourselves, will develop protective reflexes around stuff that's threatening. So if your experience is it's really scary and you're not in control, that will mean that every time you feel a twinge in your back, it freaks you out, it takes you back to that event. And it's almost like a post-trauma event that it replays in your mind. Now we know you can't eradicate that. You can only build a stronger experience on top of it. And so what we do with people who are frightened of bending, we give them hundreds of bends. We get them to do it so many times that they know they can do it. And we get them to do it awkwardly. So people are frightened of moving and bend. We give them bending programs, and we give them bending and twisting programs, and we give them programs where they bend and lift. So it's almost like you try and train them out of that fear. And then we tell them if they have a flare-up, they've got to change the way they respond to the pain so they don't panic. So those people need a lot more care than people who are not frightened, for sure, because they're much more vulnerable. Much more vulnerable.
Now, you've been talking about patient's perspective. Now, from therapist perspective, how would you build the therapist's confidence in being able to communicate well with their patients and to educate them in the right way? Do you have any tips or ideas on how physiotherapists can build this skill?
Well, that's what we're doing here across this 2 days. So that's one of those reasons. I think, one of the things around building confidence is partly your own confidence in your body. So I think if you're frightened about your own back, you're going to have a hell of a job trying to tell other people that it's safe to use their back. So part of it comes from your own personal experience. If you're guarded and protective about your back, you're probably going to teach other people to do the same thing. If you're happy and relaxed to move and bend in a normal way, you're much more likely to encourage other people to do likewise. So train yourself first. That'd be my first thought. Educate yourself. Educate yourself on this research. So we're putting up lots of this information up on that PainEd website. We, follow us on Twitter because we'll push this information out to you to try and disseminate it as best we can. So educate yourself on what the evidence is, because I think it's really important to be empowered by what the evidence is. There's good evidence out there for what we're talking about now. And there's been a huge explosion of research in the last 10 years. That means we're not just wondering, we've got really good evidence for this. The third thing is take your time to listen to your patients and explore with them about practicing differently or broadening the way you practice. So start examining the things that people tell you they can't do. So often we put a patient on the bed and we do our examination on them, and it's got nothing to do with what they can't do. When you ask the person what they can't do, they're frightened of bending and picking up the child. So we say, look at what they're doing when they pick up the child. What is it that they're doing that's painful? So spend the time looking at the things that are the concern for the patient would be the other thing. And then be brave enough to try something different. I think that's the other thing. But practice it on yourselves and with your friends before you try it out on your patients. It's probably a good idea, so that you're not quite going. Because people will pick up a lack of confidence pretty quickly. If you don't quite know what you're up to, or you're backing off and they jump because they hurt, you jump, and that's going to fall apart very, very quickly. So probably a number of factors in there come up. But it takes time to change how you think. Some people pick this up really quickly because they go, yeah, that makes sense, that's how I think. And look, physiotherapists generally are positive, great communicators, they love movement, they're interested in facilitating healthy lifestyles. So we're the best group of people to adopt this approach of thinking. So I don't think it's hard to make that shift, but we've got to almost pull out all the things we were taught in undergraduate, and probably from our parents, around sitting up straight, pulling in your belly, put those things in the bin and replace them with other thoughts. Because the beliefs that we've been, pain is something that we learn about from the very youngest moment we're born. We're encultured about how to deal with pain by our parents. I was lucky as a young kid. I had a parent who I'd fall out of the tree, she'd tell me not to worry about it. I got sent to school with broken arms. I was given pain wasn't given a lot of attention in my home, and I think that's taught me to be brave around pain. I do. I think it's had an influence on how I think about pain.
That's a factor. People growing up with this concept of fearing pain, that if you've got pain, that might be limited to
That's
more
right.
serious consequences.
That's right.
So yeah, I think education or maybe coaching starts with
It is.
us growing
It is. Well, we've done research on this, looking at 14-year-olds.
over protection.
And what we've seen is that if you have a parent with back pain, your child's more likely to get back pain. If your parent has sought treatment for their back, the child's more likely to. If the parent is frightened, the child's more likely to be frightened about back pain. So these are things that grow very early in life. That's why they're so hard to change. But that's why we have to educate a population about it as well. And if you're dealing with adolescents, you've got to educate the family. It's not just the child, because we'll see this. The parents going, don't pick up your school bag, be careful what you lift. These school bags, they're terrible things because these kids are carrying them. We've done research on school bags, and we've found that if the child is taken to school in the car, and they're more likely to report that the school bag is painful than if the child walks to school or bikes to school with the school bag. If they're conditioned to carry it, it won't be a problem. But if they're not conditioned to carry it, it will be a problem. So we tell the parents, you got to toughen your kids up. You got to toughen them up. You got to get them conditioned to carry a school bag. There's no risk in carrying a school bag. They probably need, put a few more bricks in it, and toughen them up, toughen those kids up. But if you're worrying about it, and the parents are worrying about it, like, oh, be careful, kids, and watch your posture, and we get all that information. Pull your belly in and do all this stuff. No wonder we've encultured a population to worry about the back. Oh, you're going to damage your back by lifting that heavy school bag. We see it all the time. The media picks it up. Every year in February, we get contacted by the media. They don't do it now because we won't play their game. They go, oh, look, school's going back. Can you give us guidelines of what's going to damage these kids' back? I'm going, no, that's a terrible message. Tell them that back should be trusted, that carrying school bags makes them tougher. Tell them that it'll improve their bone strength and get their muscle endurance better. Oh no, we can't. That's a terrible story. That won't sell. We want to give something that's frightening.
Are you aware of any research finding a real association between school bags and developing scoliosis?
No.
In your back?
No.
Because there's so much emphasis on this.
Yeah.
That
No. Zero.
So
It's a belief. It's another belief system. And scoliosis doesn't cause back pain, by the way. There's no increase of risk of back pain if you've got scoliosis.
No, I mean the development of
Yeah,
scoliosis.
no, there's not. No.
So that's something
Yep.
that's not like
Correct.
that.
You could pick out pretty much any belief around back pain, and I could refute it.
I'm not talking about back pain.
Yeah, no, scoliosis itself. No, no evidence.
A lot of those big people with scoliosis haven't felt any pain.
No, that's right. You're right. No, there's no evidence for it. They don't really know. There's some really interesting evidence around scoliosis, around the connectivity of the right and left side of the brain. So there are some recent studies showing that there's some altered connectivity between right and left side of the brain that they think alters the development and functioning of the skeleton. So it's probably something much more, fundamentally around the development of the right and left side of the brain structure. We don't know. Anything else?
A lot to comprehend, and to take on in one night. Don't you think?
Yeah, of course. It's all fun though. So if you're interested, follow us on Twitter, look at the website. There's lots of material out there that we put out, and others are putting out some good stuff. So it's not just our group, there are other groups around the world who are also promoting this kind of evidence-based view around managing pain. And it's it's something that we want to try and spread and share. I know you guys have embraced these kinds of concepts in your program. I think it's fantastic because the more people who are promoting that, the better it is for society.